Dan, the medic.
Hello and welcome to another lecture in the lecture series. Today's topic is sickle cell syndrome, and this is a request from my teacher of medical genetics. So, hello, teacher. So, what are sickle cell syndromes? Basically, they are part of the group of hereditary hemoglobinopathies, and then hereditary meaning that it's inherited. You might ask what pattern of inheritance? It's actually autosomal recessive. So we have different forms of this sickle cell syndromes. We have the homozygous form, also known as sickle cell disease, and it's the most common variant of sickle cell syndromes, and it mainly occurs in Africa and also the East Mediterranean area. The sickle cell trait is also another form, and this sickle cell trait is heterozygous, meaning that you have one normal allele and then one sickle cell allele. And then we have some other rare types in which you have one sickle cell allele and then you have another allele of another pathology. So it can either be another allele of HBC or another allele of HP beta thalassemia. So as for the epidemiology, I basically stated that already in the introduction. It mainly affects Africans and then East Mediterranean people. It has the highest prevalence in Africa. About 30% of Africans have sickle cell traits, meaning that they are carriers. And the sickle cell anemia is the most common form of intrinsic hemolytic anemia worldwide. So let's talk a little bit about genetics. I stated earlier that it's an autosomal recessive disease, and then we have different forms. Basically, we have heterozygotes, which are carriers of the disease. We have homozygotes, which are people that have sickle cell disease. Basically, they have two sickle cell alleles. The way this occurs is by point mutation of the beta globin gene, which then leads to replacement of glutamic acid for valine. And then by so doing, we will have two normal alpha globin and then two mutated beta globin subunits. And then this creates the pathological hemoglobin known as hemoglobin S. And in some cases, there can also be replacement of this glutamic acid with lysine, and this is known as hemoglobin C. If you remember, I said that there are some rare forms of sickle cell disease or sickle cell syndrome whereby there is presence of sickle cell allele and then also presence of another allele. So that other allele can also be the hemoglobin C. So in this case, we have hemoglobin SC disease. Now, this hemoglobin SC disease is actually a little bit or quite more severe than the like the sickle cell trait. The people that are heterozygotes, it's more severe than that, but it's less severe than people that have the sickle cell disease, meaning that they will have fewer sickling events. So let's talk a little bit about the hemoglobin composition in sickle cell disease. So basically, we know that in normal people, they have about 95 to 98% of adult hemoglobin. People that are carriers of this sickle cell or people that have sickle cell trait, they have about 60% of adult hemoglobin. Whilst people that have sickle cell disease, full-blown disease, that's their homozygotes, have 0% of this adult hemoglobin. As for hemoglobin S, of course, normal people will not have any hemoglobin S. People that are free of this disease will not have hemoglobin S, but people that are carriers of this disease will have about 40% of hemoglobin S, while people that are sicklers or people that are homozygous for sickle cell disease will have about 75 to 95% of this hemoglobin S. Now, as for the fetal hemoglobin, in normal people it's less than 2%. People that have sickle cell trait also less than 2%, but in sicklers they have about 5 to 25%. The reason for this high fetal hemoglobin will be discussed a little bit later. So now let's talk about the pathophysiology. So basically, when this hemoglobin S is deoxygenated, there is polymerization, and this polymerization causes deformation in the erythrocytes. And this is usually triggered by any condition that can lead to reduced oxygen. So when someone climbs high altitudes, we know that there is decreased oxygen saturation in that area, so it can trigger sickling. And there's one thing to point out, that in homozygotes, if there's just a little decrease in the oxygen amount in an environment, it can actually trigger this sickling event. But in heterozygotes, it takes like severe reduction of the oxygen for them to actually develop this sickling event. Also, another thing that can result in deoxygenation of hemoglobin S is infections, of course. Another cause again can be dehydration, or in the case of acidosis, or even sudden changes in temperature. Also, stress and pregnancy can reduce the amount of oxygen circulating in the blood. And we know that these sickle cells, unfortunately, when they are polymerized, they lack elasticity, and then they stick to the vascular endothelium, and this disrupts microcirculation and causes occlusion of the vessels. And then this prolonged occlusion of the vessels can lead to tissue infarction. Now, as time goes on, there is extravascular hemolysis because there is phagocytosis by splenic macrophages, and intravascular hemolysis because of the mechanical damage. And as time goes on, this hemolysis results in anemia. And then, as time goes on, there will be folate deficiency. And also, the body has to increase production of fetal hemoglobin to compensate for this low level of adult hemoglobin in sickle cell disease. Hence, the reason for the high percentage of fetal hemoglobin in patients with sickle cell disease. So, in this video, we will assume that this is a patient with sickle cell disease, and then there is presence of oxygen. So you can see they retain their normal shape, but now in the absence of oxygen, you see they begin to sickle and they adhere to the vascular endothelium. So now let's talk a little bit about the clinical features of sickle cell trait. So basically, in most patients or in most people that have sickle cell traits, they are asymptomatic. But in some cases, you can see the patient complaining of gross hematuria that comes without pain. And this is mainly due to renal papillary necrosis, which is often the only symptom that patients might present. Then, in some cases, they will have hypostenuria. They might have nocturia and enuresis. They might have recurrent urinary tract infections. They might have renal medullary carcinoma. And very rarely, symptoms of sickle cell disease may occur as a result of severe oxygen deficiency. This has to be very, very severe oxygen deficiency, because you have to remember they still have normal hemoglobin circulating in their blood. So it is only when this oxygen deficiency is very severe, that's when the abnormal red blood cells with pathological hemoglobins can actually cause maybe occlusion of the blood vessels or any other damage. So it has to be very, very severe oxygen deficiency. So now, moving on to sickle cell disease, we have to know that in approximately 30% of patients, the symptoms develop in the first year of life, and about 90% of patients will have gotten some symptoms by the age of 6 years old. Now, typically, it manifests after 6 months of age because the production of hemoglobin F, that's fetal hemoglobin, decreases, and then the production of sickled hemoglobin or hemoglobin S increases. Now, we have acute symptoms, and an example of these acute symptoms is acute hemolytic crisis. This acute hemolytic crisis is further divided into splenic sequestration crisis and aplastic crisis. So, as for the splenic sequestration crisis, we have splenic vaso-occlusion, which then leads to entrapment and pooling of large amounts of blood in the spleen. Then this leads to acute left upper quadrant pain, anemia, reticulocytosis, and signs of intravascular volume depletion. And as for the aplastic crisis, we have red blood cell aplasia with an acute severe drop in hemoglobin and associated reticulocytopenia due to an infection with parvovirus B19. Dysmorphic erythrocytes in sickle cell disease and hereditary spherocytosis are susceptible to parvovirus B19 infection, and this can temporarily suppress bone marrow erythropoiesis. Another possible cause of this aplastic crisis can be due to hyperhemolysis, whereby there is intravascular and extravascular hemolysis that is triggered by just mild oxygen deficiency, but it's quite rare. So we've discussed acute hemolytic crisis. Now, another acute symptom is infection. So now, because of what happens to the spleen and splenic infarction, there is susceptibility to infections. So in these patients, there will be presence of pneumonia, meningitis, osteomyelitis. There can also be sepsis. Another acute symptom is presence of vaso-occlusive events. So in these patients, we will see a vaso-occlusive crisis, which is some episodes of severe pain, and then they are usually recurrent in nature. And the way it is that you feel as if there's a deep bone pain and also dactylitis. This is the most common symptom in children and also adolescents. Another example of vaso-occlusive event is acute chest syndrome, also priapism. There can also be stroke as an example of vaso-occlusive event. So in this case, it will be ischemic stroke. And then also, there can be acute sickle hepatic crisis, which manifests as pain in the right upper quadrant. We see jaundice in these patients, nausea, hepatomegaly, and fever as well. Then there can be infarction also of any organ as part of the vaso-occlusive event, because we know that when the oxygen levels are decreased, there's higher tendency for adherence to the vascular epithelium. So when there is adherence of this vascular epithelium in large amounts, then blood is no longer able to flow to the organ, and the organ that is mainly at risk or that is mainly affected is the spleen, but it can happen to absolutely any organ. So now that we've talked about the acute symptoms, let's talk about the chronic symptoms. So there can be chronic hemolytic anemia, and this is manifested by fatigue, weakness, pallor, and then this is usually well tolerated. Then we have chronic pain. There's also presence of cholelithiasis, and in this case, it is pigmented stones. Now, just to make us understand, the symptoms of other forms of sickle cell syndrome, that's for instance hemoglobin SC and then also hemoglobin S beta thalassemia, are quite similar to sickle cell disease, but they are less severe. So we still see all these conditions, or like at least few of them, but of course they are less severe than in sickle cell disease. So now, how do we diagnose sickle cell disease? There's a test called prenatal testing, which is test done before delivery, and that's during pregnancy. And this is usually done in a few cases. And this is done by chorionic villus sampling and DNA analysis at 8 to 12 weeks of gestation. Now, the mandatory test that everyone does is the neonatal screening. So, immediately after childbirth, we do blood test, and this test is usually done with blood sample that is taken from the heel. So when we do this test, and then if we see that it is positive, we repeat the test again. And this test I forgot to mention is hemoglobin electrophoresis, basically. And this confirms the diagnosis and distinguishes between heterozygotes and homozygotes, another form of sickle cell syndrome. So, in older children and adults, we can do liquid chromatography and isoelectric focusing to quantify hemoglobin subtypes. And then also, we can do sickle cell test, which detects sickle cells in blood smear under anaerobic conditions. But we have to bear in mind that this particular test does not distinguish between sickle cell anemia and sickle cell traits. Then, we can do peripheral blood smear. And what we see in this peripheral blood smear is basically the sickle cells, also known as drepanocytes. We can see target cells. We can see reticulocytosis. And of course, we can also see our jolly bodies, which are signs of loss of function of the spleen or functional asplenia. On X-ray of the skull, we can see hair on end sign, which is due to periosteal reaction to erythropoietic bone marrow hyperplasia. So now, we have patients that have sickle cell disease. Of course, we have to treat this patient because they can die, or they will constantly be in pain, or they will have some infections. So basically, it's divided into long-term management and then management of acute sickle cell crisis. So for long-term management, we have to prevent infections. So we administer vaccines on time, pneumococcal vaccines, meningococcal vaccines, and the other vaccines. And then if there is suspicion of sepsis, we have to treat with third generation cephalosporins. We have to constantly give prophylaxis with penicillin. And then, of course, if there's any other condition, we treat appropriately. Then, in order to prevent vaso-occlusive crisis, we have to avoid triggers. So you try to avoid a place where you know there's going to be less oxygen, or you avoid any situation that will put you in a state of stress, basically. So that's the way to prevent. Then we can also use hydroxyurea, which is the first line treatment. And we use this if there's frequent acute painful episodes or other vaso-occlusive events. Also in the case of severe symptomatic anemia. One thing we have to remember though is that when using this drug, it has some side effects. It can cause myelosuppression, and then it can also cause some atypical form of macrocytosis. So bear that in mind. So if this hydroxyurea is not doing what you want it to do, if the response is not enough, you can combine it with erythropoietin, or you can do blood transfusion. We use L-glutamine for treatment of pediatric sickle cell anemia. And then we also have to know the adverse effect of this particular drug. It can cause constipation, it can cause nausea, it can cause cough, it can cause headaches. So we have to understand that there are also some side effects. But in this case, the side effects are nothing compared to what can happen if it is not treated. Then, because of the increased hemolysis, we have to supplement with folic acid. And then, in the case of gallstones, cholelithiasis, we can recommend cholecystectomy. And then in the case of splenic infarction or lack of function of the spleen, we can recommend splenectomy. It can either be complete or partial. Now, in the case of acute sickle cell crisis, how do we manage this? We have to treat by supportive therapy, and number one is hydration, so proper hydration. Pain management with NSAIDs and also opioids. We can also administer thromboembolic prophylaxis. We can give oxygen in order to reduce the possibility of sickling or to reduce the amount of cells that are already sickled. Then also bed rest. Also, you can do blood transfusions, and this is usually done in cases of acute severe symptomatic anemia. So in the case of aplastic crisis. It's also indicated in the case of surgery. So we do preoperative transfusions, and then also in pregnancy. So these are the indications of blood transfusion. Also, we can do exchange transfusions, which is an automated removal of erythrocytes containing hemoglobin S and simultaneous replacement with hemoglobin S free erythrocytes. Now, the indication for this is acute vaso-occlusive crisis. The advantages include the fact that there is rapid effect, there is precise control of the amount of hemoglobin S levels, and then also there's control of iron accumulation. In this case, we don't have excess accumulation of iron. But the disadvantages include the fact that it is very, very expensive and the equipments are not readily available. And it usually requires an experienced practitioner. There is only one known curative therapy, and that is bone marrow transplantation, allogenic bone marrow transplantation. And the indications are homozygotes and children that are below 16 years with severe disease. So now let's talk about the complications. The main complication apart from death, that's organ damage. So we have multi-organ damage. So let's first of all talk about the spleen. Of course, there can be functional asplenia, and then this functional asplenia can cause increased risk of infection with encapsulated bacteria. And then, because of this functional asplenia, like I mentioned before, we will see jolly bodies in the blood smear. Then there can be kidney damage. It's mainly renal papillary necrosis. We can also see glomerulonephritis or end-stage renal failure or renal tubular disorders. As for the skeleton, we can see avascular osteonecrosis. We can see osteonecrosis of the femoral head. We can see growth impairment. We can also see osteoporosis. As for the CNS, of course, we can see recurrent strokes. As for the male genital organs, we can see priapism. I laugh when I say priapism, but this is actually a very serious condition. As for the lungs, we can see sickle cell chronic lung disease. We can see also acute chest syndrome. As for the heart, we can see cardiomegaly, a kind of cardiomyopathy. It can be heart failure, and it can also be myocardial infarction. In the eye, we can see retinal vessel occlusion. And in the liver, we can see hepatic sequestration, acute sickle hepatic crisis, intrahepatic cholestasis. Treatment-related complication is also one thing that we should know about, because with treatment comes some side effects as well. In the case of constant transfusion, we know that there can be iron overload, there can be cholelithiasis, there can also be high risk of viral hepatitis. So yeah, these are things to take note of. Let's talk a little bit about sickle cell disease and malaria. It's quite interesting that individuals with sickle cell trait are less likely to develop severe forms of malaria, and they have reduced parasite prevalence. The exact mechanism of malaria resistance is unknown, but it's presumably a result of the plasmodia being unable to multiply sufficiently within the erythrocyte. And there are also some studies that suggested that there is increased sickling in infected red blood cells. So the exact mechanism is not really known. More studies need to be done. So yeah, let's talk about a special patient group, and that is people that are pregnant. So sickle cell disease in pregnancy. Assessment and counseling is usually recommended before conception. Genetic counseling should discuss the probability of the child inheriting the disease, the associated risks, and pregnancy options such as the use of donor sperm, surrogate pregnancy, and adoption. Now, if conception still occurs and the mother is maybe a carrier or a sickler, what are the complications that can affect the mother? There can be anemia, there can be increased risk of sickle cell crisis, also increased risk of infections. There's increased risk of preeclampsia and thrombotic complications. There's also increased perinatal mortality and the necessity of blood transfusions. If conception still goes ahead and then the parents are either carriers or have sickle cell disease, the fetal complication can include increased risk of fetal growth retardation or restriction, low birth weight, and also preterm delivery. So how do we manage this condition? So pregnant individuals should be cared for by healthcare personnel specialized in high-risk obstetrics. Hemoglobin levels should be measured monthly. Evaluate the need for venous thromboembolism prophylaxis and transfusion therapy. In sickle cell crisis, analogs to treatment in non-pregnant individuals. However, you must avoid use of NSAIDs. That's the end of the video. Be sure to leave a like and subscribe if you haven't.